Explain the significance of the photoelectric effect in diagnostic radiology. How does this phenomenon influence image quality and patient dose? Answer: the photoelectric effect occurs when an incident photon transfers its energy to an inner shell electron in an atom, resulting in the ejection of that electron. This process is significant in diagnostic radiology for several reasons. Image quality. The photoelectric effect is more prevalent in materials with high atomic numbers, such as bones, compared to soft tissues. This differential absorption contributes to the contrast seen in radiographs, allowing for clear delineation between various tissues. The greater the photoelectric absorption, the darker the area will appear on the image. Patient dose. The photoelectric effect is also crucial concerning patient radiation dose. High Z materials absorb more photons through the photoelectric effect, which means that images can be obtained with lower exposure settings. However, excessive exposure can lead to deterministic effects, such as skin burns or other tissue damage, particularly at higher doses. Clinical relevance. Understanding the photoelectric effect allows radiologists to optimize imaging protocols and use contrast agents effectively to enhance visibility of structures, particularly in mammography, or when assessing bone density. Compare and contrast deterministic and stochastic effects of radiation exposure. In what scenarios might each type of effect be observed, and how does this understanding influence radiation safety protocols? Answer: deterministic effects. Definition: deterministic effects are radiation effects that increase in severity with increasing radiation dose. They have a threshold dose below which they do not occur. Examples: acute radiation syndrome, skin burns, cataracts, and organ damage. Observation scenarios. These effects are often observed in occupational exposures where doses can exceed threshold levels, leading to observable symptoms. Stochastic effects. Definition: stochastic effects occur by chance and are proportional to the dose without a threshold. The probability of occurrence increases with dose, but the severity is independent of the dose. Examples: cancer induction and genetic mutations. Observation scenarios. Stochastic effects are more likely to be observed in populations exposed to low doses of radiation over time, such as in atomic bomb survivors or patients receiving low-dose radiotherapy. Influence on radiation safety protocols. Understanding the differences between these effects is crucial for developing radiation safety protocols. For instance, protocols must ensure that deterministic effects are prevented through dose limits for occupational exposure. Strategies to minimize stochastic effects may include using shielding, maintaining safe distances, and following the ARARA principle for patient exposures. Regulatory guidelines. The U.S. Nuclear Regulatory Command (NRC) sets exposure limits to prevent deterministic effects, while the National Institute for Occupational Safety and Health (NIOSH) emphasizes minimizing stochastic risks. Mr. Smith is a radiologic technologist who regularly performs fluoroscopy procedures. Recently, he noticed that he sometimes forgets to wear his lead apron during procedures. Discuss the potential implications of this oversight and the regulatory requirements regarding radiation protection for occupational exposure. Answer: Mr. Smith's oversight in not wearing a lead apron can have significant implications for both his health and compliance with radiation safety regulations. Health risks. By not using protective gear, Mr. Smith is exposed to scattered radiation during fluoroscopy, which increases his risk of deterministic effects, e.g., skin burns, and stochastic effects, e.g., cancer. The cumulative exposure over time can significantly heighten these risks, especially considering the high dose rates associated with fluoroscopic procedures. Regulatory requirements. The Occupational Safety and Health Administration (OSHA) and NRC regulations mandate that healthcare facilities implement adequate radiation protection protocols. This includes ensuring that all personnel wear appropriate personal protective equipment (PPE) like lead aprons during procedures. Facilities must conduct regular training sessions on radiation safety and ensure compliance through monitoring practices such as dosimetry badges for staff to track exposure levels. Corrective actions. Mr. Smith should be reminded to adhere to radiation safety protocols and the importance of wearing PPE. His facility should reinforce the need for continuous education on the dangers of radiation exposure and the legal ramifications of non-compliance. Institutional policies. The facility should have policies that encourage staff to report any lapses in safety measures without fear of repercussion, thus fostering a culture of safety and accountability. Define linear energy transfer, LET, and relative biological effectiveness, RBE. How do these concepts affect the selection of radiation therapy techniques? Answer: linear energy transfer, LET. Definition: LET refers to the energy transferred by radiation to the material, tissue, per unit distance traveled. It is expressed in kevmom. High LET values indicate that the radiation deposits energy more densely along its track. Types alpha particles have a high LET, while X-rays and gamma rays have a low LET, relative biological effectiveness, or B. Definition. RB compares the biological effectiveness of different types of radiation in producing a biological effect, typically measured against 250 kV X-rays. It is defined as the ratio of the dose of reference radiation to the dose of test radiation that produces the same biological effect. Effects on radiation therapy techniques. High LET radiation, the G protons, heavy ions, tends to have a greater RBE, leading to more significant biological damage for the same physical dose. This allows for more targeted treatments that minimize damage to surrounding healthy tissues. Conversely, lower LET radiation, the G X-rays, requires higher doses to achieve similar effects, which may increase the risk of side effects. Treatment planning should account for these factors to maximize tumor destruction while preserving normal tissues. Regulatory guidelines. The American Society for Radiation Oncology (ASTRO) recommends considering LET and RB when developing treatment protocols, particularly in advanced radiation therapies such as proton therapy. What are the different types of radiation monitoring devices, and how do they function in ensuring compliance with radiation safety standards? Answer. Radiation monitoring devices are crucial for measuring and ensuring compliance with radiation safety standards. Key types include thermoluminescent dosimeters (TLDS). Function. TLDS measure exposure by absorbing radiation energy and releasing it as light upon heating. The amount of light emitted correlates with the dose received. Application. Commonly used for personnel monitoring in healthcare settings due to their accuracy and ability to measure a wide range of doses. Optically stimulated luminescence dosimeters (OSLs). Function. OSLS works similarly to TLDS but use light stimulation instead of heat to release the stored energy. This allows for real-time readings. Application. Used for environmental monitoring and personnel dosimetry, providing more detailed dose distribution information. Ionization chambers. Function. These devices measure ionization caused by radiation in a gas-filled chamber. They provide immediate readings of exposure rates in various environments. Application. Commonly used in radiation therapy for quality assurance and in laboratories for measuring radiation levels. Compliance with radiation safety standards. Monitoring devices must be calibrated regularly to ensure accuracy. Facilities must maintain records of personnel exposure and ensure that exposure limits set by the NRC and OSHA are not exceeded. Regular audits and inspections should be conducted to ensure that all monitoring devices are functional and that personnel are adhering to safety protocols. Discuss the pathophysiology of acute radiation syndrome (ARS). What are the clinical signs and how should healthcare professionals respond to a suspected case? Answer. Pathophysiology of ARS, acute radiation syndrome, occurs when a person is exposed to high doses of ionizing radiation over a short period. The severity of ARS depends on the radiation dose and the rate of exposure. Cellular damage. High doses of radiation damage rapidly dividing cells, such as those in the bone marrow, gastrointestinal tract, and skin. This leads to a reduction in blood cell production, impairing immune function and increasing susceptibility to infections. Dose-response relationship. 2Gi. More severe symptoms develop, including severe hematopoietic and gastrointestinal syndromes, leading to potential death without intervention. Clinical signs of ARS. Early symptoms include nausea, vomiting, and diarrhea. As the syndrome progresses, signs of bone marrow failure, e.g., anemia, leukopenia, thrombocytopenia become evident, along with potential gastrointestinal hemorrhage and infection. Response to suspected cases. Immediate assessment. Healthcare professionals must assess the level of exposure and classify the severity of ARS. Supportive care. Administer fluids, antiemetics, and possibly blood products to manage symptoms and support hematologic recovery. Isolation precautions. Implement strict infection control measures due to the risk of opportunistic infections from neutropenia. Long-term monitoring. Patients who survive ARS should be monitored for delayed effects, including the potential development of cancer. Regulatory guidelines. The National Institute for Occupational Safety and Health (NIOSH) provides guidelines for managing radiation exposure incidents, emphasizing the need for rapid response protocols. What are the key factors that must be considered when selecting a dosimetry technique for a specific radiological procedure? Discuss how these factors influence patient safety and treatment efficacy. Answer: when selecting a dosimetry technique for radiological procedures, several key factors must be considered. Type of radiation, different types of radiation, e.g., X-rays, gamma rays, alpha particles, require different dosimetry techniques. For instance, ionization chambers are effective for measuring X-ray doses, while TLDS may be better for mixed radiation fields. Energy range. The energy of the radiation impacts the dosimeter's sensitivity and accuracy. Higher energy photons may require different calibration or measurement techniques compared to lower energy radiation. Environment. The clinical setting, e.g., hospital versus outpatient facility, may influence the choice of dosimetry. In a high-dose radiation therapy setting, real-time monitoring may be preferred to ensure safety and compliance with dose limits. Measurement precision. The required precision for the procedure should guide the choice of dosimeter. Techniques that provide real-time measurements may be necessary for procedures requiring high accuracy, such as stereotactic radiosurgery. Patient considerations. The dosimetry method should ensure that patient safety is prioritized, minimizing unnecessary exposure. Understanding the patient's medical history and potential sensitivity to radiation is crucial. Impact on patient safety and treatment efficacy. Selecting appropriate dosimetry techniques ensures that radiation exposure is monitored effectively, contributing to patient safety by adhering to the ALARA principle. Accurate dosimetry is essential for treatment efficacy. Underdosing a tumor may lead to treatment failure, while overdosing can increase the risk of side effects. Regulatory guidelines. The American Association of Physicists in Medicine (OPM) provides guidelines for radiation dosimetry, emphasizing the need for accurate measurement techniques to enhance patient safety and treatment effectiveness. Distinguish between ionizing and non-ionizing radiation, providing examples of each. Discuss the implications of exposure to each type in the context of health risks and safety regulations. Answer: ionizing radiation. Definition: ionizing radiation carries enough energy to remove tightly bound electrons from atoms, creating ions. This includes gamma rays, X-rays, alpha particles, and beta particles. Examples: medical imaging, X-rays, CT scans, radiation therapy, gamma knife, and naturally occurring radiation, radon. Health risks. Exposure to ionizing radiation can lead to deterministic effects, e.g., skin burns, and stochastic effects, e.g., increased cancer risk. Regulatory bodies set exposure limits to protect against these risks. Non-ionizing radiation. Definition: non-ionizing radiation does not have sufficient energy to ionize atoms or molecules. This type includes visible light, microwaves, radio waves, and ultraviolet UV radiation. Examples: MRI, magnetic resonance imaging, ultrasound, and UV tanning beds. Health risks. Non-ionizing radiation is generally considered less harmful than ionizing radiation. However, excessive exposure can cause thermal effects, e.g., burns from microwaves, or photochemical damage, e.g., skin cancer from UV exposure. Implications for health risks and safety regulations. Regulatory frameworks. The International Commission on Radiological Protection (ICOP) and the World Health Organization, who provide guidelines for the safe use of both ionizing and non-ionizing radiation, emphasizing risk assessments and exposure limits. Safety protocols. Healthcare facilities must implement appropriate safety measures based on the type of radiation used. This may include personal protective equipment (PPE) for ionizing radiation and patient education on the risks of non-ionizing radiation. Analyze the roles of the Nuclear Regulatory Command (NRC) and the Occupational Safety and Health Administration (OSHA) in regulating radiation safety in healthcare settings. How do their guidelines complement each other? Answer: the NRC and OSHA play crucial roles in regulating radiation safety within healthcare settings. Nuclear Regulatory Command (NRC) role. The NRC oversees the use of radioactive materials in medical applications, ensuring public health and safety. They establish regulations for the licensing and operation of facilities that use radioactive substances. Guidelines. The NRC provides guidelines regarding exposure limits, training for personnel, and the safe handling of radioactive materials. These regulations aim to minimize unnecessary radiation exposure to patients and staff. Occupational Safety and Health Administration (OSHA) role. OSHA focuses on protecting worker health and safety in various industries, including healthcare. They establish regulations that ensure safe working environments free from hazards, including radiation. Guidelines. OSHA guidelines include exposure limits for ionizing radiation, requirements for personal protective equipment (PPE), and training on recognizing and mitigating radiation hazards. Complementary roles. Overlap in responsibilities. While the NRC focuses on the regulation of radioactive materials, OSHA ensures that the working environment is safe for healthcare workers handling these materials. Training and compliance. Both agencies require training for healthcare professionals on radiation safety, albeit from different perspectives. Their combined efforts help foster a culture of safety that protects patients and healthcare workers alike. Conclusion. By understanding the roles of the NRC and OSHA, healthcare facilities can implement comprehensive safety protocols that comply with both agencies' regulations, thus enhancing overall safety in radiological practices. Discuss the potential effects of radiation exposure on a developing fetus during different gestational periods. What guidelines should be followed when a pregnant patient requires radiological procedures? Answer. Radiation exposure during pregnancy can have significant implications for fetal development, with the potential effects varying based on the timing of exposure. First trimester 0–2 weeks. Risks. This period is critical for organogenesis. High doses of radiation 0.1 Gi can lead to teratogenic effects, resulting in congenital abnormalities or miscarriage. Effects. Potential effects include growth retardation, organ malformations, and cognitive deficits. Second trimester 1–3–6 weeks. Risks. While the fetus is less susceptible to malformations, the risk of cancer induction increases with exposure. Doses above 0.5 Gi may lead to hematological disorders and neurodevelopmental issues. Effects. The developing nervous system can be particularly vulnerable, with potential long-term effects on cognitive function. Third trimester 2–7–40 weeks. Risks. The fetus is less sensitive to radiation effects, however, exposure can still lead to reduced birth weight and other growth issues. Effects. The risk of childhood cancer remains a concern with significant exposure. Guidelines for radiological procedures. ALARA principle. Healthcare providers should apply the ALARA as low as reasonably achievable principle when imaging pregnant patients to minimize exposure. Risk assessment. A thorough risk assessment should be conducted before any imaging procedure. If possible, alternative imaging modalities, e.g. ultrasound or MRI, that do not use ionizing radiation should be considered. Informed consent. Pregnant patients should be informed of the risks associated with radiation exposure, and consent should be obtained before proceeding with radiological procedures. Regulatory guidelines. The American College of Radiology (ACA) and the Radiological Society of North America (RSNI) provide guidelines for imaging pregnant patients, emphasizing safety and the importance of minimizing radiation exposure. What are the key imaging characteristics that differentiate benign from malignant tumors in cross-sectional imaging techniques like CT and MRI? Answer. The differentiation between benign and malignant tumors in imaging relies on several factors, including tumor borders, enhancement patterns, and growth behavior. Margins. Benign tumors tend to have well-defined, smooth borders, while malignant tumors often show irregular, spiculated, or infiltrative borders due to invasion into surrounding tissues. Enhancement patterns. In contrast, enhanced CT or MRI, benign tumors generally demonstrate uniform or minimal enhancement, while malignant tumors exhibit heterogeneous enhancement due to necrosis, hypovascularity, or aggressive angiogenesis. Growth rate. Benign tumors usually grow slowly and maintain a stable size over time, while malignant tumors may exhibit rapid growth, involvement of surrounding structures. Malignant tumors frequently invade adjacent structures, e.g. vessels, bones, whereas benign tumors typically do not. The presence of metastasis, particularly lymph node enlargement or spread to distant organs, further supports a diagnosis of malignancy. Additionally, advanced imaging modalities such as diffusion-weighted imaging (DWI) in MRI can be utilized to assess tissue cellularity and aid in distinguishing between benign and malignant lesions based on differences in apparent diffusion coefficient (AC) values. Mr. Thompson, a 55-year-old male with a history of hypertension, presents with sudden onset of severe headache and visual disturbances. A CT scan without contrast shows a hyperdense crescent-shaped collection along the right hemisphere. What is the most likely diagnosis, and what imaging findings support this conclusion? Answer. The most likely diagnosis for Mr. Thompson is a subdural hematoma. This condition is typically associated with a crescent-shaped hyperdense area on non-contrast CT imaging as blood collects between the dura mater and the brain parenchyma. The hyperdensity of the blood is a key feature, especially in the acute phase 1 3 days. Subdural hematomas are often caused by tearing of bridging veins due to trauma or spontaneous rupture, particularly in patients with risk factors like hypertension. Additional signs that support this diagnosis include mass effect, compression of adjacent brain structures, midline shift, or effacement of sulci, delayed presentation. In some cases, subdural hematomas may present days to weeks after minor trauma, especially in elderly or hypertensive patients. Treatment typically involves surgical intervention such as a craniotomy or butthole drainage if there is significant mass effect or neurological compromise. Describe the role of MR perfusion imaging in the assessment of stroke and how it helps in determining tissue viability. Answer: MR perfusion imaging is a critical tool in stroke assessment, especially for determining the extent of ischemic penumbra viable but at-risk tissue versus the ischemic core irreversibly damaged tissue. MR perfusion imaging uses parameters like cerebral blood flow (CBF). A reduction in CBF indicates ischemia, but if the CBF is drastically reduced, it suggests infarction. Cerebral blood volume (CBV). A low CBV generally indicates infarcted tissue, whereas a normal CBV in the setting of reduced CBF may indicate salvageable tissue. Mean transit time (MTT). Prolonged MTT suggests a delay in perfusion, which can occur in both the penumbra and infarcted regions. Time to PTTP. This parameter helps in identifying areas of delayed perfusion, often correlating with the ischemic penumbra. By evaluating these parameters, physicians can determine which areas of the brain may benefit from reperfusion therapy, such as thrombolysis or mechanical thrombectomy. Identifying the ischemic penumbra is crucial for treatment decisions in the acute phase of stroke management, especially within the 4.5-hour window for thrombolytic intervention. In trauma imaging, how does CT contrast-enhanced imaging aid in diagnosing active hemorrhage, and what are the critical imaging findings to look for? Answer: in trauma settings, contrast-enhanced CT is highly effective for identifying active hemorrhage. The key findings that suggest active bleeding include active contrast extravasation. This appears as a high attenuation contrast leak on arterial phase images and is one of the most specific indicators of ongoing hemorrhage. It may enlarge on delayed images as contrast continues to extravasate into surrounding tissues. Pseudocoagulant. This refers to areas of contrast pooling within a hematoma, which can be mistaken for a pseudoneurysm or active extravasation. Delayed imaging helps differentiate these findings. Hemoperitoneum or hemothorax. The presence of free intraperitoneal or intrathoracic blood, particularly if dense, indicates prior or active bleeding, although without active contrast extravasation, it may represent contained hemorrhage. CT is also useful for identifying the source of the bleeding, such as vascular injury, solid organ damage, e.g. liver, spleen, or fractures with arterial involvement. MS. Garcia, a 45-year-old woman, presents with left-sided weakness and slurred speech. An MRI reveals an enhancing lesion in the right parietal lobe. Based on the imaging findings, the differential diagnosis includes primary brain tumor and metastases. What additional imaging techniques can be used to further differentiate these possibilities? Answer: to differentiate between a primary brain tumor and metastases, several advanced imaging techniques can be employed. Diffusion-weighted imaging (TWI). Metastatic lesions often show restricted diffusion due to higher cellularity, while primary brain tumors like gliomas may have more variable diffusion characteristics depending on the grade. Perfusion-weighted imaging (PI). Higher perfusion is typically seen in high-grade primary brain tumors due to neoangiogenesis, while metastases tend to show more heterogeneous perfusion patterns. Magnetic resonance spectroscopy misses. This technique evaluates the metabolic profile of the lesion. Increased choline levels with decreased N-acetylaspartate (NA) is suggestive of high-grade malignancy. Lipid lactate peaks are commonly seen in necrotic metastases. These modalities, when combined with the clinical history and conventional imaging, provide a comprehensive assessment of the lesion's nature and guide further management decisions. What is the role of vascular imaging in diagnosing an abdominal aortic aneurysm, and what specific findings are indicative of an impending rupture? Answer: vascular imaging, particularly CT angiography, ETA, and ultrasound, plays a central role in diagnosing and monitoring abdominal aortic aneurysms. Key findings on imaging that suggest an impending rupture include aneurysm size. An aneurysm diameter greater than 5.5 centimeters is considered at high risk for rupture, and rapid expansion, 0.5 centimeters in 6 months, also increases risk. Periaortic hematoma. The presence of a crescent-shaped area of hyperattenuation surrounding the aorta, known as the crescent sign, indicates contained rupture, aortic wall thinning, and discontinuity. Weakening and thinning of the aortic wall may be seen in impending rupture. Intramural hematoma. A hyperdense crescent within the aortic wall, particularly on non-contrast CT, indicates a high risk of rupture. Regular imaging follow-up for patients with small AAS is crucial, and elective surgical repair is typically recommended for aneurysms larger than 5.5 centimeters to prevent rupture. Explain the imaging features of multiple sclerosis (MS) on MRI and how different sequences help in the diagnosis and staging of the disease. Answer: MRI is the gold standard for diagnosing and monitoring multiple sclerosis (MS). The imaging features of MS on MRI include twitted hyperintensities, multiple white matter lesions, particularly in periventricular, juxtacortical, infratentorial, and spinal cord regions, are characteristic of MS. These lesions are typically hyperintense on twitted and FLAIR sequences. Gadolinium enhancement. Active demyelinating plaques often enhance with gadolinium, reflecting inflammation and breakdown of the blood-brain barrier. This helps differentiate new or active lesions from chronic ones. Twitted hypointensities. Black holes. These represent areas of chronic axonal loss and demyelination, indicating more advanced disease. The McDonald criteria for diagnosing MS emphasize the importance of disseminated lesions in time and space, which MRI can document effectively, especially with follow-up imaging to monitor the appearance of new lesions. Mr. Williams, a 60-year-old smoker, presents with hemoptysis and weight loss. The CT scan reveals a 3 cm spiculated mass in the left upper lobe with associated hilar lymphadenopathy. What is the most likely diagnosis and what imaging features suggest this? Answer: the most likely diagnosis for Mr. Williams is lung cancer, specifically non-small cell lung cancer, given the imaging findings. Key imaging features that support this diagnosis include spiculated mass. The presence of spiculated margins indicates aggressive growth and is highly suggestive of malignancy. Size: a mass greater than 2 centimeters raises concern for cancer, particularly in a patient with risk factors like smoking. Hilar lymphadenopathy. Enlargement of lymph nodes in the hilum can indicate regional metastases and further supports the diagnosis of lung cancer. Ground glass opacity or consolidation. These findings may also be present, indicating associated changes in the surrounding lung parenchyma. Additional imaging, such as PET-CT, can help assess for distant metastases and guide treatment decisions. What is the significance of identifying inflammatory changes on imaging in conditions such as pneumonia, and what typical imaging features would you expect to find on a chest X-ray and CT scan? Answer: identifying inflammatory changes on imaging, particularly in cases of pneumonia, is critical for diagnosis and management. Typical imaging features include chest X-ray. Lobar consolidation. Homogeneous opacity in a specific lung lobe indicates alveolar filling, often seen in bacterial pneumonia. Air bronchogram. The visibility of air-filled bronchi on an opaque background due to surrounding consolidation. Pleural effusion. Blunting of the costophrenic angle may suggest fluid accumulation. CT scan. Ground glass opacity DDO represents partial filling of air spaces and can indicate interstitial pneumonia or early stages of lobar pneumonia. Consolidation. More definitive than on X-ray, indicating denser fluid-filled alveoli. Nodular opacities may suggest atypical infections such as fungal or viral pneumonia. Early identification and differentiation of pneumonia type through imaging can significantly influence management strategies, including the choice of antibiotics or the need for further invasive procedures. Discuss the role of molecular imaging in the assessment of cancer and how it can enhance the understanding of tumor biology. Answer: molecular imaging provides insights into the biological behavior of tumors beyond mere anatomical information. Key modalities include positron emission tomography (PET). This technique measures metabolic activity, with 18-FGG-fluorodeoxyglucose being the most commonly used radiotracer. Increased uptick often correlates with tumor aggressiveness and can aid in assessing treatment response. Single photon emission computed tomography (SPECT), while less common than PET/SPE. CT imaging can provide functional information regarding blood flow and receptor activity within tumors. Hybrid imaging (PET/PETRI). These approaches combine metabolic data with anatomical imaging, improving localization of lesions and helping in staging and restaging. Molecular imaging is also instrumental in the development of theranostics, where specific radioligands target tumor-specific antigens or receptors, facilitating both diagnostic and therapeutic interventions. Understanding these biological markers can guide personalized treatment strategies, improving patient outcomes in oncology. What are the key factors that should be considered when choosing between an interventional radiology procedure and a surgical alternative for a patient? Discuss the relative risks and benefits. Answer: when deciding between an interventional radiology, a procedure, and a surgical alternative, several factors must be considered. Minimally invasive nature. IR procedures tend to be less invasive, leading to faster recovery times and reduced post-procedural pain. Surgical procedures, while more invasive, may be necessary in cases where complete visualization and direct access to the problem area are critical. Patient condition. Patients who are poor candidates for surgery due to age, comorbidities, or overall health may benefit from the less physically taxing nature of IR procedures. Risk of complications. Surgical procedures carry high risks of infection, bleeding, and anesthesia-related complications compared to IR procedures. However, IR procedures may have their own risks, such as radiation exposure or complications like vessel perforation. Outcomes and efficacy. In some cases, surgery offers a more definitive or permanent solution compared to IR procedures. For example, complete tumor resection in cancer cases is more definitive than embolization, which may require repeat treatments. Mr. Thompson, the 72-year-old male with chronic kidney disease, presents for placement of a peripherally inserted central catheter, PICC line due to his need for long-term intravenous antibiotics. During the procedure, the IR team encounters significant difficulty due to tortuous veins and a prior history of multiple access sites. What should the IR team do in this situation, and what are the safety considerations? Answer: the IR team should follow these steps. Assess the anatomy and previous interventions. Tortuous veins and multiple previous access attempts increase the complexity of the procedure. Ultrasound guidance is essential in ensuring accurate placement and avoiding puncturing the vessel. Alternative access routes. If conventional venous access via the upper extremities is unsuccessful, the IR team may consider alternative access routes such as a tunneled central venous catheter or jugular subclavian access. Safety considerations. It is critical to avoid multiple puncture attempts in the same location to prevent vessel damage, bleeding, or infection. Additionally, minimizing radiation exposure through optimized fluoroscopic techniques is important. Post-procedure care. Monitoring for complications such as infection or bleeding at the site is crucial. A chest X-ray may be warranted to confirm proper catheter placement and rule out complications like pneumothorax. Relevant guidelines. The Society of Interventional Radiology recommends that vascular access procedures follow strict safety protocols to minimize complications such as infection, thrombosis, and vessel injury. Explain the difference between mechanical thrombectomy and catheter-directed thrombolysis for the treatment of deep vein thrombus DVT. What factors influence the choice of one over the other? Answer: mechanical thrombectomy is a technique that physically removes thrombus, clots, from blood vessels using a variety of devices, e.g., suction catheters, rotating or aspiration devices. It is typically used in cases of acute DVT or in patients who cannot tolerate thrombolytic agents. Catheter-directed thrombolysis CDT involves the infusion of thrombolytic agents directly into the clot via a catheter. This is a slow process but can be more effective in breaking down extensive clots. Factors influencing choice: acuteness of clot. Mechanical thrombectomy is preferred for acute large clots where rapid removal is critical. CDT is used for more extensive or chronic clots. Patient contraindications. Patients with bleeding risks or contraindications to thrombolytic agents are better suited for mechanical thrombectomy. Clinical presentation. In cases of life-threatening situations, e.g., pulmonary embolism with hemodynamic compromise, thrombectomy may be preferred for rapid clot resolution. Compare and contrast radiofrequency ablation (RFA) and cryoablation in terms of mechanism, indications, and potential complications. Answer: radiofrequency ablation (RFA). It uses thermal energy to generate heat and destroy targeted tissues. Commonly used for treating tumors such as liver or renal tumors and arrhythmias. RFA relies on electrical currents to create heat, leading to coagulative necrosis. Cryoablation uses extreme cold to destroy tissue by freezing. This technique is often used for prostate cancer, lung tumors, or certain cardiac arrhythmias. The mechanism of cell death is via the formation of intracellular ice crystals, leading to cellular rupture and death. Indications: RFA is more commonly used for tumors with well-defined borders and those close to heat-sensitive structures. Cryoablation is often chosen for tumors close to critical structures, e.g., the diaphragm nerves, as it provides a more controlled ablative zone with less collateral damage. Complications: RFA risks include thermal injury to surrounding structures, post-procedural pain, and infection. Cryoablation Complications include cryoshock, systemic inflammatory response, nerve injury, and potential damage to nearby structures if not carefully controlled. Discuss the indications, risks, and long-term outcomes of angioplasty and stenting for peripheral arterial disease (PAD). How does this compare to surgical revascularization? Answer: indications. Angioplasty with or without stenting is indicated in patients with PAD who have significant symptomatic stenosis or occlusion of peripheral arteries, particularly those experiencing claudication or critical limb ischemia. Risks. Risks include arterial dissection, restenosis, embolization, and access site complications, e.g. hematoma, infection. Long-term outcomes. While angioplasty and stenting offer less invasive alternatives to surgery with quicker recovery times, they may have higher rates of restenosis compared to surgical bypass, particularly in long segment occlusions. Comparison to surgical revascularization. Surgical bypass offers more durable long-term results, especially in patients with more extensive disease. However, it involves greater risks due to its invasiveness, including infection, wound complications, and longer recovery times. Relevant guidelines. The American College of Cardiology (AC) and American Heart Association (AHO) recommend angioplasty and stenting as first-line therapies for PAD, especially for shorter stenoses and patients who are poor surgical candidates. In which cases would endovascular aneurysm repair (VAR) be preferred over open surgical repair for abdominal aortic aneurysms (EAR), and what are the critical post-procedural monitoring considerations? Answer: VAR is preferred in patients with AAA who are at higher risk for open surgery due to age, comorbidities, or the presence of other risk factors such as respiratory or cardiac conditions. The VAR is less invasive and associated with shorter hospital stays, quicker recovery, and lower immediate morbidity and mortality rates. Post-procedural monitoring considerations. Endolac detection, a critical complication that requires lifelong surveillance with imaging, e.g. CT angiography or duplex ultrasound. Graft migration. Regular follow-up is necessary to detect movement of the stent graft, which can lead to aneurysm expansion and rupture. Relevant guidelines. The Society for Vascular Surgery (SVS) guidelines recommend lifelong imaging surveillance post-EVAR due to the risk of complications like endolac or graft failure. What techniques can be implemented to minimize radiation exposure to patients and staff during fluoroscopic procedures? Answer: to minimize radiation exposure during fluoroscopic procedures, the following techniques should be employed. Use of pulse fluoroscopy. Utilizing pulse rather than continuous fluoroscopy significantly reduces radiation exposure by providing images only when necessary. Collimation. Adjusting the collimator to focus on the area of interest reduces the radiation field, thereby limiting unnecessary exposure to surrounding tissues. Distance and positioning. Maximizing the distance between the radiation source and the patient as well as the operator reduces exposure. Operators should stand behind lead shields when possible. Lead shields and protective equipment. Use lead aprons, thyroid shields, and protective eyewear for all personnel involved in the procedure. Monitoring and adjustment of fluoroscopy time. Continuous assessment of imaging needs should be performed, adjusting fluoroscopy times accordingly. Keeping track of cumulative dose exposure can also be beneficial. Identify the potential complications associated with interventional procedures and the protocols that should be followed to mitigate these risks. Answer: common post-procedural complications include infection. Implement proper sterile techniques during procedures and post-procedural care protocols. Antibiotic prophylaxis may be indicated based on the procedure type and patient risk factors. Bleeding. Monitoring for signs of hematoma or active bleeding post-procedure is essential. Access site pressure management and early identification of complications can prevent significant blood loss. Embolization complications. This can occur when debris dislodges during manipulation of catheters or devices. Techniques such as the use of filters, e.g. IVC filters, can mitigate risks in patients at high risk for embolization. Protocols. Adherence to specific protocols for patient selection, informed consent, and postoperative monitoring, as established by the Society of Interventional Radiology and SCR guidelines, is crucial in managing these risks. Discuss the considerations for selecting the appropriate imaging modality for an image-guided biopsy, including the advantages and disadvantages of each modality. Answer: CT guided biopsy. Advantages: provides excellent visualization of internal structures and is beneficial for deeper lesions. Disadvantages: involves radiation exposure and may not provide real-time feedback. Ultrasound-guided biopsy advantages. Real-time imaging, no radiation exposure, and relatively low cost. Disadvantages may not be suitable for deep or complex lesions where sound waves cannot penetrate effectively. MRI-guided biopsy advantages. Offers high-resolution images and is advantageous for soft tissue lesions. Disadvantages. Less commonly used due to high costs, limited accessibility, and can be time-consuming. Considerations. The choice of modality is influenced by factors such as the location of the lesion, patient safety, required level of precision, and operator experience with the respective modality. What are the essential components of post-procedure care for patients undergoing interventional radiology procedures to ensure patient safety and optimal recovery? Answer: post-procedure care is crucial for ensuring patient safety and includes monitoring vital signs. Regular monitoring for changes in heart rate, blood pressure, and respiratory status is critical to detect complications early. Site assessment. Careful inspection of the access site for signs of bleeding, hematoma formation, or infection is essential. Pressure dressings may be applied, and the patient should be instructed to report any unusual changes. Patient education. Providing the patient with clear instructions on activity restrictions, signs and symptoms of complications, and follow-up care is vital for recovery. Pain management. Effective management of pain through appropriate analgesics and monitoring for pain levels helps in enhancing patient comfort and satisfaction. Relevant guidelines. The SIR and ACR provide comprehensive guidelines for post-procedure care in interventional radiology, emphasizing the importance of patient monitoring and education to minimize risks and optimize recovery.